So our objectives for today is to describe the pathogenesis and differential diagnosis of chronic rhinosinusitis and how to decide when patients need to be managed by a specialist in rhinology or otolaryngology. Neither Dr. De La Hoz nor myself have any financial conflicts of interest to disclose for today. So what is chronic rhinosinusitis? It's obviously a very large public health issue. Lots of money goes into it, and it has a significant impact on patients' quality of life. You may not believe this, but diabetes, cardiac disease, very similar quality of life impacts. And in terms of the World Trade Center population, it is the most common adverse health effect. We're going to first start with nomenclature here. We use the term rhinosinusitis, which emphasizes the fact, if you look at this diagram, the mucous membranes of the nose are in strict continuity with the mucous membranes of the sinuses as well. And the same process is going on in parallel in both. So even though there are some compartmentalized situations where it's really limited to the nose or it's really limited to one sinus, the term rhinosinusitis, I think, is more specific for most people where it's a situation that impacts the entire rhinologic tract. When we talk about rhinosinusitis, and probably one of the biggest things that I want to get through to everybody today, in terms of all of rhinosinusitis, whether it's occupational or environmental or the standard population, chronic rhinosinusitis overwhelmingly is an inflammatory disorder. It is not an infectious disorder. So the inflammation is propagated from patients' exposures to environmental stimulants, not so much by bacteria or viruses setting trap. And there'll be a slide later to kind of illustrate that, but that's what we're trying to get across today. When we talk about occupational rhinosinusitis, very often there's coincidental situation with the lower airway as well. And we know this by the fact that histologically speaking, it's indistinguishable, the lower airway to the upper airway, and the same inflammatory mediators take place in both the lower airway and the upper airway. So it's not a coincidence that Dr. De La Hoz, who mainly treats lower airway issues, sees a lot of patients with chronic rhinosinusitis and these upper airway situations. So we have worked together a lot in these past several years, and we have a patient illustration today, which will kind of show just that, how most of these patients don't have disease isolated to the lungs or isolated to the upper air digestive tract, but there is a comorbid situation there. One other thing just worthy to mention is the presence of atopy in the WTC exposed workers we have found to not be higher than that of the general US population. So what are some of the occupational factors? Well, patients at work can be exposed to the whole gamut of sensitizers, both those that normal population would be exposed to, but then there are other situations where further allergens or irritants may be present. And we tend to classify these as either being high molecular weight or low molecular weight. The high molecular weights are basically any type of organic compound or microorganism or the vegetable-based products. The low molecular weight are the mostly the organic and inorganic solvents. So the isocyanates, which would be used in for the use of certain plastics and whatnot, and the persulfate salts, which are more like rubber and tire industry types of products, as well as, diesel cleaning chemicals uh, and other inorganic compounds. And needless to mention, firefighters as a whole separate entity with all of the gamut of exposures on any given day. So we have made a couple of observations with regards to occupational exposure to certain things and who may be more likely to require repeat operations. And those that have repeated exposures at work will correlate with needing further operations, and specific entities will also correlate. And all of these irritants can cause olfactory impact, sinonasal atrophy and atrophic rhinosinusitis, ulceration. We have seen septal perforations as a result of both the irritants themselves and the patient's over-the-counter use of products to try to deal with their underlying rhinosinusitis, dysplasia, inflammatory situations such as granuloma formation and even sinonasal carcinomas. If you notice, I'm actually scrubbed right now doing a sinonasal cancer case. Fortunately, I have a colleague that's working with me as well, so we're working in tandem here today. So one of the most helpful things, and this is useful for both otolaryngologists and non-otolaryngologists alike, is exposure to this international consensus statement on allergy and rhinologic issues, or ICARs. It was most recently updated extensively in 2021, and most of the things apply. And this statement includes both the discussion in inflammatory endotypes, the development of the different therapies, how we operate on these patients, understanding the parallel lower and upper respiratory tract issues, as well as just standardization of nomenclature, and just a really good look at how this impacts the population. So this is what it will look like if you want to do a PubMed search for that article. So now we're going to go into a little bit of the evaluation of these patients. We're going to discuss the symptom types, what predisposing factors may be playing a role there, what they may look like on examination, and what other lab values may be helpful. There are many different classifications of chronic rhinosinusitis. This is a very busy slide, but it is reasonably complete in terms of determining both the allergic components, the non-allergic components, whether or not these patients have predisposing issues, both genetic and non-genetic, both anatomic and at a molecular level. But it's worthwhile. I'm sure most of you have encountered patients in all of these categories at one point or the other. Dr. DeLos and I have made this table about 15 years ago, and we've obviously updated it from time to time, but for the most part, it still stands the test of time. And it really is intended for primary care providers and non-otolaryngologists to really get a good assessment of how to manage these patients. So the patient presents with certain rhinosinusitis symptoms. Immediately, you want to decide if there are any alarm signs, so unilaterality, if there's bleeding associated, if there's severe pain or complete disability, then they may require immediate evaluation. Otherwise, we can kind of go down in the chain. Initially, most of these patients can benefit from saline nasal rinses plus or minus a topical nasal steroid trial. If you have any index of suspicion for allergy, it would be reasonable to check this as well. And then we can try, if they are allergic, you can try the medications that are really designed specifically for allergy, such as bupropion modifiers, systemic antihistamines, topical antihistamines. If they're non-allergic, topical nasal steroids can still be helpful for those patients, but you can consider an anticholinergic such as the ipratropium, and in certain cases, systemic decongestants can be helpful as well. So for on the right side of the screen, those patients that are continue to have a problem, this is when allergy referral may be helpful and possibility of immunotherapy could be considered. And in any of those situations on either side, if they continue to have problems, that's when we consider imaging. They may need more systemic treatment with corticosteroids or antimicrobials. And it's generally a good time to consider otolaryngologic evaluation at this point too, where a CT can be reviewed. We can decide if there are any anatomic components. We can actually physically look in there and make sure that there's nothing concerning for another entity. And so that's where we would usually start to get involved. And then even with or without surgery, the last 3 or 4 years has given us a whole wealth of exposure to the biologic treatments, which can sometimes be used prior to surgery, sometimes used after surgery, and definitely worthy of mentioning in this talk today. So in order to really try to illustrate things, we're going to go over the case of a 48-year-old NYPD police officer, lifetime non-smoker, who presented to Dr. De La Hoz initially for treatment. Part of her history, she was exposed initially on day 1 of September 11, 2001. She did have severe asthma and had multiple exacerbations, but never required intubation. She did have coincident gastroesophageal reflux with hiatal hernia, which did prompt management. She's also been diagnosed with mild obstructive sleep apnea. Given those symptoms and the placement of topical anti-inflammatories, including antihistamines, her symptoms continued to worsen, and she ultimately was referred for otolaryngology evaluation. Some other specs is the high peripheral eosinophilic count and the fact that she did have some elevation of IgE with tree and ragweed pollen sensitization. She did not have cats and dogs, though she was allergic. This is a scan from 2010, so prior to any surgery, and I just want to illustrate a couple of things that are anatomic factors for patients with chronic rhinosinusitis, namely this black ball structure, which is an pneumatization of the middle turbinate we call a concha bullosa, which really closes the infundibulum or the outflow tract of the sinuses, and independently is a risk factor for recurring episodes of acute rhinosinusitis and is present in many cases of chronic rhinosinusitis and usually is worth addressing as well as the inflammatory disease in the maxillary sinuses that we see on these images here. So, we go through the table like we did before. This patient made it as far as the CT scan. We did see correctable anatomic problems, so she did go through surgical intervention. And that was performed by another otolaryngologist back in 2011. She did experience initial improvement. She started to have more pulmonary issues in about 2019, And then her nasal symptoms really started to progress as well, despite the fact that she was placed on both leukotriene inhibitors as well as systemic antihistamines. The asthma symptoms progress, as well as the fact that her headaches continued. And she discussed that in retrospect. She never really did notice resolution of her headaches from immediately after the initial operation. So a new CT scan was done in 2021, which reveals opacification of her sphenoid sinus. So we'll kind of go over here. Remember, this was all grayed out from her inflammatory disease in the maxillary sinuses before. The concha bullosa was bivalved and the lateral lamella was removed. So the outflow tract is better there. However, she does have unilateral sphenoid sinus opacification, and that independently is a huge factor for headache. So I, at this point, had the ability and opportunity to see the patient. We initially went back, we rewound, and we just wanted to make sure she was doing the right thing. She had a prior operation, so we used topical nasal steroids added to the sinus rinses with hopes of that having some anti-inflammatory benefit. But despite that, the headaches persisted and really became quite disabling for her. And so we offered revision surgery in 2023. Fortunately, we ultimately did get complete clearance of all the paranasal sinuses. Her headaches immediately improved, which was obviously a nice adjunct. But again, surgery takes care of the anatomic components. It takes care of some of the more acute complaints, but it does not take away the patient's underlying sensitivities. And this patient is no exception to that. She continues to have upper and lower airway disease that requires long-term management, including laryngeal dysfunction, which may have some relationship to her allergy and some relationship to the underlying hiatal hernia and GERD, but that's been treated as well. So most of what we just discussed was going to be presented by Dr. De La Hoz, and I was going to kind of take over right around here to just go over what we do when we see a patient in an otolaryngology clinic for management. And I'm sure all of you are familiar with our endoscopes. It used to be that these were fiber optic scopes, and they had multiple little light fibers that ran across the inside portion of the scope, both in rigid and in flexible forms. And you could put your eye up to this end and see at the end here, and it would be somewhat magnified. That's no longer the case. There's basically just a camera at the tip of this. This is a driver and something to get the scope into the patient, but it's all digitized. So there's only one tiny fiber that connects the camera to the camera head here and to the monitor. So we do use those scopes for evaluation. We're big on evaluating the patient with inventories. I like to use the SNOT-22 and the nose scores because they've been shown to correlate with pre and post-operative treatments, and they've been reproducible in many situations, and many otolaryngologists throughout the country use them, so they've become a more standardized means. And if you go back to that Icahn document, they are the inventories of choice. We don't just look at the mucous membranes inside the nose. We look at all of the areas that may be factors inside the nose, the nasopharynx, the area of the eustachian tubes. Many of you have probably noted the coincident otic complaints in patients with rhinosinusitis and postnasal drainage. That's no coincidence, actually. It's the fact that anatomically these are inseparable factors as well. And the exam does extend all the way down to the laryngopharynx, essentially the cervical portion of the esophagus into the hypopharynx here is where our exams start. So this is what one can see in a speculum view when a patient's received decongestant. This is an old slide, but I think it still illustrates. This is the patient's left side. This is the patient's right side. And you can see how much more you can evaluate once the patient has received decongestant. Middle turbinate is up here, but much more available for our evaluation once they've received the decongestant. Here you can't even see the middle turbinate, but you can actually see the vast majority of it. That's without endoscopy. This is just with speculum view. You can get that view. Now, if we're getting the endoscope in there, I just kind of want to show you a vantage point of somebody with chronic rhinosinusitis. So you see that thickened, discolored mucus coming from the middle meatus there. It drains postnasally. And on this side, we can also see that nasal septal deformity, not only buckling up the premaxillary crest, but a septal spur as well. So these are all anatomic factors that may require some management at some point. So I want to now go back. So we discussed we had that very busy slide of rhinosinusitis subtypes. I'm not going to go over all of them, but I will go over the ones that you all encounter on a reasonably regular basis and how we make the distinctions. So we discussed patients with chronic rhinosinusitis with or without polyps. And then the other entity is recurring acute exacerbation of chronic rhinosinusitis. So these patients have baseline symptoms, but the symptoms progress very often after an environmental exposure, an occupational exposure, or they just get a cold or a virus, and then they've already got swelling and minor closure of these outflow tracts of the sinuses, and things really flare up. And sometimes those can be bacterial exacerbations. Now, that's not to be mistaken by typical acute rhinosinusitis, which is a normal population patient that doesn't generally have nasal obstruction. They don't generally have congestion or nasal drainage, but they get a cold or a virus or they have some other exposure, and then they develop the symptoms right after that. And we manage those people significantly differently because there are usually many different factors related. And those acute sinusitis patients can be divided into the one-offs, the ones that get maybe one every year or two or something like that, to the recurrent acute, where anytime they get a cold or virus or an occupational exposure, they get a flare up and they end up seeing somebody, maybe have to go on antibiotics. And then now go back up to the top, the chronic rhinosinusitis with polyps patients. We subdivide those now into central compartment polyps versus sinus polyps. And it's a very important distinction because their endotypes are different. The central compartment patients are almost exclusively atopic, IgE-mediated inflammatory pathways. And so we have different options for them than we do for the patients that have more diffusely disseminated polyps and their management. So we can go over a little bit of that as well. So definition-wise, up to 4 weeks is still where we qualify acute rhinosinusitis. They'll get that facial pain and pressure. They generally feel well, though, but they get exposure to a virus or bacteria or some other type of thing. This is what they look like on exam. They literally have pus draining out of their sinuses. It's usually red and angry looking. If you do happen to get a scan on those patients, which these patients generally do not need scans unless they keep recurring, or if they have warning symptoms. Last week I was on call at the hospital, so anything that came into the ER of complication of rhinosinusitis, we would have to see. And sure enough, a patient with acute sinusitis, never had symptoms in his life, presented not only with severe sinus pressure and headaches and purulent nasal drainage, but evolving mass in his frontal region. So you can see basically a horn coming out of his forehead. And this is an entity called a Pott's puffy tumor, which is an isolated, well, not an isolated, but it includes a frontal sinusitis, but the inflammation is so severe that it causes erosion of the anterior table of the frontal sinus, thus the abscess in the subcutaneous area, as well as posteriorly, these patients can get epidural empyemas and brain abscesses as well. Fortunately, last week's patient simply had the subcutaneous process and we were able to manage everything endoscopically. But this is the type of acute inflammatory findings that you see with these air fluid levels and the bubbling. The frothy bubbles are more consistent with an acute process. So most non-complicated patients, we give them topical decongestants. So aspirin at night, maybe like pseudoephedrine during the day, plus or minus something for the pain. And most of these patients improve with that treatment alone. If they do have pus, then they'll need systemic antibiotics. And only the more severe cases, like I had mentioned, require surgical intervention. We don't treat surgery in the acute setting very lightly. The operations tend to be bloodier, they're not as elegant, and honestly, the inflammation is generally so bad that a lot of the openings that we create, we have to watch them so closely to make sure that those inflammatory processes don't cause cicatricial closure of them or scarring of the ostia. So those patients have to be followed much more closely, and we try to avoid it if we can. We try to wait till things cool down, and then we have the opportunity in those situations where they have recurring infections to go back and address those anatomic components that may be predisposing them. Balloon sinuplasty, which many of you have probably heard of, that's where it really is most useful. It can address a lot of these natural blockages of the sinuses, and with a relatively non-invasive procedure with minimal blood loss, these patients can be dilated and do very well for a long time. So it has become a valuable instrument in the hands of many otolaryngologists. There is some crossover where some people are using it for chronic inflammatory issues, and it does play a role in some, but certainly not in all of these patients. So chronic rhinosinusitis definition is 12 weeks or more, so 3 months, 3 months of symptoms in order to be classified as chronic. They may or may not have mucopurulent drainage, nasal congestion, facial pain, pressure, fullness, as well as post-nasal drainage. Olfactory acuity may also be affected. We generally consider this to be either related to inadequate mucociliary function or obstruction. It is not an infectious entity, so antibiotics are generally not necessary for the management of chronic sinusitis unless they have an acute bacterial exacerbation. A major component is eosinophilia in many of these more challenging patients. These barrier dysfunctions and the immunologic things have been and the inflammatory pathways have been studied much more over these last 5-10 years. It's become a big business in pharmaceuticals for both the asthma indications as well as the chronic sinusitis with polyps indications as well. So going back, so like I said at the very beginning, chronic rhinosinusitis primarily is an inflammatory type 2 thing. So more than 80% of cases are this type 2 inflammatory thing, which is mediated by either IL-4, IL-5, IL-13, which have an extremely close relationship to serum eosinophils, and less so with mast cells, but they can. And so that nasal polyps, asthma, olfactory issues, as well as the pressure and those other symptoms are very often prevalent here. We call type 1 endotype of sinusitis more of the virally mediated thing. So a patient develops a virus, it kind of lingers for a while, even up to 3 months, and then clears. But these patients generally have different cellular endotypes and require different treatments. Rarely do these patients require surgery. Usually they just require anti-inflammatories for a prolonged period of time just to allow things to cool down. And type 3 are more of the bacterial components. So these are the patients mostly with staph that have some sort of endotoxin and biofilm, and it's probably a separate entity, and it tends to be more surgically weighted here, where surgery is more of a cure than actually just an adjunct treatment. And then we'll go just real quickly. Allergic fungal sinusitis is a whole other entity which you may have been exposed to. These are the patients with, polyps practically coming out of their nose. They do have a type 1 hypersensitivity, usually to mold or fungus. If you take the mucus, it's eosinophil laden. They'll very often have positive fungal staining. Their CT scans show that little halo of essentially Charcot-Leyden crystals, or the major basic protein that's degranulated and just sets up shop here, and eventually causes destruction of bone, where you can actually see erosion, sometimes of the lamina, and mucopyocele or mucocele formation as well. And one final thing are the patients that have already had surgery, but they keep getting infections after any exposure. So these are the acute exacerbations of chronic rhinosinusitis, and it can come both in bacterial and non-bacterial. So this is a patient with a flare-up, but it's really just diffuse swelling there, but it's not actually an infection. So we'll treat them with usually topical corticosteroids if they've had surgery. Now, central compartment atopic disease is it's a topic that's really been brought up within the last 10 years. So these people, it's more polypoid degeneration of their middle turbinates, possibly their inferior turbinates, usually at the posterior aspect. These are almost always IgE mediated, and these patients have atopic disease. And so it's treated as such. Sometimes the polyps do need to be removed, but it's very much an immunologic issue. And so the coincident treatment with either immunotherapy or IgE modulators can be helpful. These tables are getting harder and harder to produce because they're changing all of the time. This one kind of shows where most of these biologics play a role for the management of chronic rhinosinusitis. Not every chronic rhinosinusitis patient needs them, but there are certain patients that just have refractory symptoms that benefit from them, namely the ones with refractory polyps or recurring acute on chronic rhinosinusitis. I'm not going to go into too much detail here, but essentially most of these are designed to either address IL-4, IL-5, or IL-13 at the earlier stages, but there are newer products that are available that will affect things at a more proximal level. Tezspire or tezepelumab is the most recent of these. So it's addressing things at the TSLP level where IL-4, 5, and 13 are actually produced. So it's a more proximal thing. It'll cause broader effects. There are some early studies for chronic rhinosinusitis with polyps, but it's not an indication yet, and I have not used it myself, so I can't really give you much more. But it does show some promise there. So just kind of in summary here, surgery, I think, is still a very important adjunct for the management of chronic sinusitis, especially with and without polyps. But the biologics sometimes are playing a little bit more of a role here. I think it's important to think of surgery not only as a way to remove the polyps, but also for us to be able to manage these people more closely after surgery. So once we have good access to things, we know that these sinus rinses and anti-inflammatories can get up into all the sinuses, keep that inflammation at bay. And very often these patients, if they have a properly performed operation, can avoid these biologics, and sometimes they can't. But This is a relatively low morbid procedure, which really can change a person's life and kind of turn things around. So in conclusion, chronic rhinosinusitis is a lot more than what you would think it would be in terms of how it affects a person's quality of life and the coincident uh, problems. There are many factors in terms of its etiology. Hopefully you have an idea of what the subtypes are and how each thing is managed a little bit differently. And very importantly, which patients require evaluation by an otolaryngologist sooner rather than later. So if there are any things that require more acute management.